This podcast of the People's Pharmacy is brought to you by Molecule, Molekule. For $75 off your first order, visit molecule.com. That's molecule with a K. At checkout, enter the promo code JOE, J-O-E.
Health experts have been telling us for decades to cut back on salt. How strong is the science supporting this advice? This is the People's Pharmacy with Terry and Joe Graydon.
Dr. Aaron Carroll, Associate Dean for Research Mentoring at Indiana University School of Medicine, says the scientific support behind drastically cutting salt is surprisingly weak.
We don't have the evidence. We think we know what we're talking about. We tell everyone what to do no matter how hard it is or whether it's impossible. We see equivocal results, and then we wonder why no one wants to listen to us as physicians. It's troubling.
Coming up on the People's Pharmacy, your calls and questions about standard health recommendations and pain relievers.
First, this news.
In the People's Pharmacy Health headlines, a life-threatening drug-resistant fungal infection is spreading around the country. The CDC is reporting outbreaks of Candida auris in 12 states. New York, New Jersey, and Illinois have been especially hard hit. The first case of C. auris was detected in Japan a decade ago. No one had paid attention to it before, because it wasn't causing any trouble, but once it became drug-resistant, it started to overwhelm people with impaired immunity. 3 years ago, 7 cases were discovered in the U.S. Now the CDC has confirmed that nearly 600 individuals have been infected with Candida auris. Many of these patients had weakened immune systems and were hospitalized. In such individuals who can't mount a strong immune response, the infection is often lethal. Researchers suspect that heavy use of agricultural fungicides may have contributed to the development of drug resistance by C. auris and possibly some other fungal infections as well. This parallels the evolution of drug-resistant bacteria such as MRSA that evade the usual antibiotic treatments. Worldwide, experts estimate that the annual death toll from such superbugs, including both bacteria and fungus, may be as high as 700,000 people. Because Candida auris has spread so quickly, we are likely to see more outbreaks in the near future.
The FDA has just approved a new drug for osteoporosis that works differently than existing medications. Romosozumab will be sold under the brand name Evenity. This injectable monoclonal antibody actually builds bone, unlike many prior medications that work primarily by slowing bone breakdown. The FDA has only approved Evenity for postmenopausal women who are at very high risk of bone fracture. There will be a black box warning that the drug can increase the risk for cardiovascular complications such as heart attacks and strokes. Less worrisome side effects include injection site reactions, joint pain, and headaches. Evenity is injected once a month for 12 months. After that, patients will likely need to switch to a different osteoporosis drug to maintain bone density. One analyst predicts the cost will be approximately $600 a month.
How do whitening strips make your teeth so white and sparkly? The active ingredient is hydrogen peroxide, well known as a bleaching product. Unfortunately, it might not be healthy for teeth. Scientists presented research demonstrating that hydrogen peroxide can damage the dentin layer of teeth that lies just below the enamel. In extracted teeth, hydrogen peroxide can break down the collagen in the dentin. Dentists are not convinced, however, that this is a problem in everyday use.
Lower back pain is common and debilitating. It's estimated that 80% of adults will experience this distressing condition sometime during their lives. Physicians often recommend nonsteroidal anti-inflammatory drugs like ibuprofen or naproxen to ease the pain. Excruciating back spasms may also be treated with opioids and or muscle relaxants. Exercise and physical therapy are other frequent recommendations. Many doctors have been somewhat ambivalent about spinal manipulation, but a new study shows that this type of treatment can be highly effective. The researchers analyzed 47 studies that included over 9,000 adults. Spinal manipulation was as effective as NSAIDs, pain medicines, and exercise. The investigators urged medical doctors to consider chiropractic and other forms of spinal manipulation for lower back pain.
New research shows that gum disease might join the list of risk factors that could increase your chance of developing Alzheimer's disease. Scientists compared brain samples from autopsies of people with Alzheimer's disease and people of similar ages without the brain condition. Distinctive DNA from Porphyromonas gingivalis, bacteria responsible for periodontitis, was more common in the Alzheimer-affected brains. P. gingivalis produces bacterial toxins known as gingipients that were also present in these brains. The investigators then conducted experiments in mice that showed P. gingivalis moves readily from the mouth to the brain. Regular brushing, flossing, and periodic visits with a dental hygienist can help keep P. gingivalis under control. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon. I'm a pharmacologist.
And I'm Terry Graydon. I'm a medical anthropologist. Today, we're discussing the health news that matters to you, and we're talking about evidence. Everyone has heard that high cholesterol is problematic, especially so-called bad LDL cholesterol. But can LDL go too low? We'll talk about that a little later. First, how good is the evidence for a salt-restricted diet?
To find out, we turn to Dr. Aaron Carroll. He is a professor of pediatrics and associate dean for research mentoring at Indiana University School of Medicine. He's a regular contributor to the New York Times feature, The Upshot. Dr. Carroll's most recent book is The Bad Food Bible, How and Why to Eat Sinfully.
Welcome back to the People's Pharmacy, Dr. Aaron Carroll.
Thank you very much.
Dr. Carroll, when I was a kid, I remember my mama going on a salt restriction phase. This is a woman who loved to put salt in her chicken soup and most other things, but she had heard that salt was bad for you, and the salt shaker disappeared from the table.
If you'll pardon my saying so, chicken soup isn't worth eating without salt.
No, it's hard to think of almost any soup that would be good without salt. It's just hard to imagine.
So fast forward 40, 50, 60 years, and we have the American Heart Association basically telling the world, salt's bad for you. You got to get it down to 1,500 milligrams of sodium a day, which is not very much.
No, it's not much at all. You know what? This is one of those things where we know that too much of something is very, very bad for you. And then we start to believe that because of that, then less would be good. And then we carry it to its natural conclusion that none would be perfect. The problem is that nothing in life is ever that simple. So there's a fairly decent amount of evidence that people who consume high amounts of sodium and who also have high blood pressure can see improvements in their health by reducing the amount of salt they're eating from something very high to less than that. That's great. The problem is that we've been just pushing it further and further down. So we get to the point where, one group, you'll have the FDA saying 2.3 grams a day. And then you'll have the WHO that says, no, it should be 2. And you'll have the American Heart Association say 1.5, when there's almost no evidence at all that these very low salt diets are good for us. In fact, there's some observational evidence that they might be bad for us.
I think we want to hear more about that. But first, Dr. Carroll, when you say high amounts of salt can be harmful, how high is high?
I mean, there are studies of people who are consuming more than 7 grams a day or even, let's say, more than 6 grams a day. And so one of the big studies that links to the fact that perhaps low-salt diets might be bad for us was a big study in the New England Journal of Medicine a couple of years ago that looked at salt consumption and excretion in many countries throughout the world, and then looked at its effects, its relationship both with bad cardiovascular outcomes like heart attacks and also with death. And they found that, yes, people who consume like 7 grams a day or more have higher rates of heart attacks and death than people who are consuming somewhere between 3 and 6. And it's important to understand that the average American probably consumes about 3.5 grams of salt a day. But what they also found was that people who consumed very low salt diets, let's say less than 2, had the highest rates of cardiovascular events and death, in that they had higher events than people who are consuming more than 7, but certainly more than people who are consuming 3 to 6. The natural argument is that, well, maybe perhaps people who were sick or told to reduce their salt intake are in that low group, and they're the ones that got sick and died. But a lot of these types of studies take that into account and actually enroll people and check to see whether they have heart disease or issues before they enter the study, before they follow them. And it just says that, hey, consuming very low salt diets puts you in almost the same category of risk as the people who consume more than 7. Now, I'm not necessarily saying that's proof that low salt diets cause these events, but it should certainly give us pause, because we don't have a lot of good evidence that these very low salt diets are good for us. And so if you have some evidence that they're bad for us and no evidence that they're very good for us, then maybe we should stop pushing those so hard and focus our attention on where it should be, the people who are consuming very high levels of sodium, to try to get them more into the normal mid-range.
I'm trying to imagine what it would be like to consume 6 to 7 grams of sodium a day. I'm thinking you'd have to eat like 5 pretzels loaded with salt. You'd have to have potato chips. You'd probably have to.
No, you also have to eat soup out of a can.
Yeah, processed foods will do it.
Right.
Absolutely.
And then you'd have to be shaking the salt shaker like crazy.
Well, ironically enough, shaking the salt shaker is not where most people get their sodium, as we just sort of push towards. It's in processed foods. The problem is that sodium is put into almost everything that we eat that is prepared for by someone else. And so most sodium you're getting is in stuff other people made for you. The stuff that you make for yourself and then add salt to is not the issue. And so I'm always sort of baffled by people who will consume a fast food diet, all these prepared processed foods, but then panic about, what they might shake over it at the end. Anyone who cooks knows that salt's essential to making food taste good, but that's not where most people are getting their salt. The people who are getting the 7 grams plus a day, it's from processed foods, it's from stuff that's already been prepared, and that's where they could do a lot better. But I would say it's not as hard to get to 7 grams as you'd think if you're eating fast food, if you're, again, eating a lot of processed foods, because it's snuck in there. But if you're cooking for yourself, then getting to 7 grams becomes much more difficult, and most people probably aren't there.
Now, Dr. Carroll, most physicians, most of your colleagues, especially your cardiology colleagues, would say, well, yeah, maybe the data isn't so great when it comes to the average person, but there's one category of patients that absolutely has to be on a low sodium diet, and those are the folks with congestive heart failure.
So heart failure is when, to be blunt, your heart just can't pump enough blood to the rest of the body. 5.5, 6 million people in the United States probably have it. High blood pressure can often lead to heart failure because it's harder for your heart to pump against that high pressure, which makes it weaker over time. And to treat it, usually we try to give you drugs that'll strengthen your heart, or by reducing the volume of your blood, either through diuretics or drugs that reduce volume, or by restricting salt intake. But the latter, and which is often pushed, believe me, has unbelievably small amounts of evidence behind it. There was a study recently published, I think it was in JAMA Internal Medicine. Researchers searched for all randomized controlled trials that looked at reducing sodium intake to treat heart failure. And in all of the medical literature, they could only find 9 studies, and one of them was only published in abstract form, so you can not even really review it. We're talking about less than 500 patients who've ever been studied for this in randomized controlled trials. None of the studies were big enough to involve 100 patients, and none of them were of good quality or low bias. And in all of this, there was really no data that showed that salt restriction would lower either mortality or cardiac disease. It wouldn't affect whether you get admitted to the hospital. It wouldn't change how long you'd stay in the hospital if you were admitted. And there was an editorial written by Dr. Clyde Yancey, who's a cardiologist at Northwestern School of Medicine, and he noted that only 0.3% of all of the studies that have looked at sodium restriction and heart failure were of decent quality to be included in this review. This is, it's maddening. The idea that this is all we've got, and based on this, we have made widespread recommendations on what people should do with their diets. And we do this far too often. We don't have the evidence. We think we know what we're talking about. We tell everyone what to do no matter how hard it is or whether it's impossible. We see equivocal results, and then we wonder why no one wants to listen to us as physicians. It's troubling.
Now, Dr. Carroll, why have your colleagues really grabbed onto this advice if the evidence is so shockingly thin?
So, part of it is that, again, I think part of it is extrapolation. We do have some evidence, again, that for people who consume large amounts of salt, reducing their salt can improve some factors in their lives. And so be it. That's what we know. We also know, in the same vein, really high cholesterol levels are bad, and that if we can get people to lower their cholesterol, that's good. We also know that, if people consume too much fat, enormous amounts that perhaps lower that. The problem is then we keep extrapolating it down and down and down to we start telling people who are consuming perhaps an average amount of these things still need to eat less because less would be better. But there's a diminishing return. We don't see these kinds of benefits at the low end. They're really not studied. We just assume they're there, and we just make recommendations that aren't based, unfortunately, on good evidence.
Dr. Carroll, are there any strong evidence-based recommendations for people with heart failure? Are there things they can and should be doing that will help them?
Well, again, if you are consuming huge amounts of sodium, I would take your doctor's recommendation to reduce it and try to consume less. There are also some evidence that increasing potassium intake might be a benefit, often because it helps lower sodium in the blood. There's also some evidence that high-fiber diets might make a difference. And we'd probably be better off trying to push for more holistically well-balanced diets like the Mediterranean diet or the DASH diet, which have both also been associated with lower rates of heart failure. And I should caution that these are still not well-studied and randomized controlled trials, but it's often easier to stick to a better food diet plan in general, take the Mediterranean diet as an example, than to just follow one hard to accomplish goal like no sodium. Again, a little salt is what makes some healthy foods taste good. If you force everyone to eat bland boiled vegetables, no one will. But if you allow them to saute them in a little bit of butter and then add a little bit of salt to make it then they might eat the vegetables. And we might wind up with people who are eating better overall if we weren't so restrictive about individual things than just making these pronouncements that no one can stick to.
Dr. Aaron Carroll, thank you so much for talking with us on the People's Pharmacy today.
Anytime.
You've been listening to Dr. Aaron Carroll, Professor of Pediatrics and Associate Dean for Research Mentoring at Indiana University School of Medicine. His book is The Bad Food Bible, How and Why to Eat Sinfully.
And we invite you to join the conversation. Our lines are open at 888-472-3366. Have you cut back on salt? We'd like to hear from you. Again, that number, 888-472-3366.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy is brought to you in part by Molecule, MolekulE. Molecule has completely reinvented air purification with new technology that destroys indoor air pollutants molecule by molecule.
Molecule's air purifier uses photoelectrochemical oxidation nanotechnology to completely remove mold, bacteria, viruses, airborne chemicals, and other allergens from the air by eliminating them. It might be hard to remember during pollen season, but pollen's not the only problem that causes allergic reactions. Tiny protein particles that escape off the pollen cause the most serious reactions, and these can slip right through most air filters. Molecule's special technology eliminates these bits of protein, so the air that's left is completely clean.
Molecule is your best defense in allergy season. It doesn't just trap allergens, it obliterates them. With Molecule, you'll have the cleanest air possible. Take a deep breath.
If you're troubled with allergies at night, you might find that Molecule offers you the best night's sleep you've had in a long time, eliminating allergens of every sort so that you're breathing clean air as you sleep can make for a more restful, refreshing night.
The unique photoelectrochemical oxidation technology that Molecule uses has been tested and verified by third parties such as Intertek, the University of Minnesota Particle Calibration Laboratory, and the University of South Florida Center for Biological Defense, Aerosol Research and Engineering Laboratories. Molecule's technology has been vetted by scientists, but even more important, it's been tested and found helpful by real people. Molecule gives allergy and asthma sufferers around the country a brand new experience.
For $75 off your initial order, visit molecule.com. That's Molecule with a K. When you check out, enter the promo code JOE, J-O-E.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. If you would like to purchase a CD of this show, you can call 800-732-2334. It's show number 1160. You can also place that order online at our website, peoplespharmacy.com.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Today we're talking about scientific evidence and some unexpected findings. We just heard from Dr. Aaron Carroll that there's surprisingly little data to support the kind of extreme recommendations on salt that the American Heart Association, the American College of Cardiology, and the FDA all make. How do you feel when you hear that conventional wisdom isn't necessarily based on science?
You can join the conversation. Our lines are open at 888-472-3366. You can email us, radio@peoplespharmacy.com. Or again, you can join the conversation at 888-472-3366. And Terry, there's another fascinating article in the news this week, and it's all about LDL cholesterol. We've been told for quite a few decades that's the bad cholesterol, and you can't get it too low. We have a cardiologist friend who used to say you can't have too low a golf score or too low a cholesterol level.
Well, he might be right about golf. I don't know. But
he's definitely right about golf.
You could have too low a golf score by doing it the way I do. You never play golf.
Yeah, but if you want to win at golf, you have to have a low score.
Yeah. However, it turns out that you can indeed have too low an LDL cholesterol. The Women's Health Study showed that women whose LDL cholesterol was under 70 actually are at higher risk, about twice the risk, for a hemorrhagic stroke. Now, bleeding strokes, hemorrhagic strokes, are not at all common, so the absolute risk probably isn't very high. Nonetheless, it's still troublesome that you're at twice as much risk than you would be if your LDL cholesterol were a little bit higher. We don't have the evidence for men. I don't know whether it's any different for men, or maybe the number would be slightly different.
There is some epidemiology, but this women's health study involved 28,000 women, and they were followed for almost 20 years. And the researchers who did this study are highly regarded. Julie Buehring And Dr. Paul Ridker, he is one of the country's leading cardiologists. He was in charge of what was known as the Jupiter trial, which showed inflammation is important in heart disease.
Yes.
And Crestor, or rosuvastatin, was the statin that was involved in that study.
They are very well-respected researchers.
Exactly. And they are reporting this doubling, not 30%, not 50%, but doubling effect on hemorrhagic stroke. Now, the Japanese have been reporting this for actually many decades, suggesting that if your LDL cholesterol, or your total cholesterol for that matter, is very, very low, there is an increased risk of hemorrhagic stroke, bleeding stroke, dangerous kind of stroke.
Now, the Women's Health Study didn't show a connection between total cholesterol and stroke risk, but it did show a connection with triglycerides. So if your triglycerides are very low, it also showed that you're at double the risk of a hemorrhagic stroke. So really, we're talking about Goldilocks here. You don't want to be too high for sure, and that's where most Americans are. You don't want to be too low. You try and hit the sweet spot.
How do you deal with such unanticipated results? The number to call to ask a question or share your experience is 888-472-3366. You can email us, radio@peoplespharmacy.com. Again, do you find this kind of data alarming, disquieting, or maybe it doesn't surprise you at all? Again, you can join our conversation at 888-472-3366.
Well, we go to Apex and talk to Doug about his low-salt diet. Hi, Doug.
Hello, Terry. I can certainly tell you how do I feel, and it's in how I feel because I have a very rare kidney condition called nephrogenic diabetes insipidus. I have had it from birth. In a nutshell, for the layman out there, I consume 2 to 3 gallons of liquid a day. So not only do I consume a lot, but I pee freely, if I can say that on the air.
Sure.
So in terms of my sodium intake, I look at it as I try to keep it right around 1,500 milligrams daily. If I go up to 2,000, 2,500, I guess I'm at the top end of my range. But beyond that, if I start to consume foods like pizza, highly processed foods, believe me, I can really feel it.
Uh-huh.
And as a 50-year-old male who is 63 inches, that would be 5'3" for those people out there, at 135, I really don't need that extra added water weight.
No, and I assume, Doug, that you have adapted to this low-salt diet and it doesn't bother your taste buds at all. In fact, I'm guessing that if you eat a lot of salt, it tastes terrible.
Exactly. And I kind of approach food from a taste point of view that actually, for me, I think a lot of food, I don't need a lot of salt because there's obviously naturally occurring salt.
Right. And Doug, I would say that it's very good that you have learned how to manage your condition and your situation. And of course, a really low-salt diet makes a huge amount of sense for you, especially since you can feel the difference.
Yeah, and because you have a rare condition. So, obviously everyone is different, and each situation is going to require adjustment.
We go to Conway, South Carolina. Katrina, welcome to the People's Pharmacy.
Good morning.
Hi, Katrina.
How you doing? I quit eating regular table salt probably in 1998, 99, when the doctor started talking to me about my cholesterol. I'm now 62, and I still don't have, my husband has regular salt, but I have the no salt that I purchased from the over the counter. Of course, you know what I'm talking about.
Right.
But then last year I had to have my thyroid removed, and after that I started reading some information that says not having regular table salt could cause your thyroid to go bad, and I was like, now I'm on medication. Have you all heard anything, read anything?
So let's talk about that a little bit, please, Katrina. So table salt in the United States is fortified with iodine to make sure that everybody gets enough iodine. Not too much, but enough. And the reason for that is that iodine is essential for the thyroid to function. So it's very unlikely that using the alternate salt that you were using, the low salt, actually is part salt and part potassium iodide. So you weren't depriving your body of the iodine that it needs. It doesn't need very much, just a tiny bit. And I don't think that would have led to the condition, whatever condition it was, that caused the doctors to say you need to have your thyroid removed.
Now, Terry, the idea of using some salts that don't have iodine could be a problem for thyroid.
It could, especially if people stick to that for an extended period of time. For example, we have an email here from Letitia who wanted to know if the boutique salts like Himalayan salt are different.
Well, let's go to Stanton, Virginia, because that is the question from Dr. Is it Kalana?
Kalaria.
Yeah, Dr. Kalana, you have a question about salt.
Hi, yes. My question is, a lot of my patients take sea salt thinking it's very safe. Can you tell me if that is safe?
Well, Dr. Kalaria, if they are using sea salt exclusively, then no. They're not getting the iodine that they might need. Now, in Stanton, Virginia, your patients may or may not be getting any seafood, and seafood is another good source of iodine. But Stanton's kind of not right on the coast, and consequently, some of your patients might not be getting the iodine they need.
Besides the iodine, is the salt safe?
The salt itself, as salt is, it's salt. It's sodium chloride. And the sea salt has maybe a few interesting impurities that give it a better flavor or texture. It might be more aesthetically appealing, but it's not it's not superior to table salt.
And it won't have any iodine.
Right.
Thank you, Dr. Kalaria. Let's go to Bill in Fort Worth, Texas, about LPA lipid not being tested for. What is this question about, Bill? Oh, it would help if I...
It would help if
I click the button. Sorry about that, Bill. We missed what you said.
Hi, I love your program.
Thank you, sir.
I had a heart attack back in 2008, and I did a lot of research on atherosclerosis. And I found out that there is a lipid called Lp(a) that almost no doctors know about and no one tests for. And it is a significant cardiac risk factor. And what I found out that not even statins can lower it. And it, I think, was a contributory cause in my heart attack. I did find that Linus Pauling has a protocol with massive doses of vitamin C, L-lysine, and proline that is significantly can reduce the risk of this problem in the arteries. I wondered if you knew anything about it or any of your other callers did as well.
Well, Bill, I have to tell you, I've been interested in Lp(a) for probably 3 decades. And you're right. As far as I can tell, statins do not lower Lp(a). I don't know of any pharmaceuticals that do. And I do think it is a risk factor for heart disease. It's hard to compare, how does Lp(a) compare to LDL cholesterol? How does it compare to total cholesterol? How does it compare to triglycerides? I don't know that we have a clear roadmap to say Lp(a) is like the worst lipid fraction, but I do think it's a risk factor, and I agree with you. I don't think very many people get tested for it, and I think it's important. I'll have to look into the Linus Pauling protocol. Thank you for sharing that. We really appreciate it.
Yeah, he said that vitamin C deficiency actually compromises the endothelium.
That probably is true. I don't know that very many Americans are vitamin C deficient, however.
You know, what's very interesting about what Bill just said was the endothelium. Now, that's the lining of the blood vessels.
Right.
And the article that was just published about LDL cholesterol being, if it's too low,
LDL cholesterol
and
being
it
a problem.
causes bleeding strokes, hemorrhagic strokes, or at least contributes to them, what's the mechanism? And Terry, one of the theories is that when LDL cholesterol gets too low, below 70, it may cause a compromise of that endothelial tissue, that one cell lining of the blood vessels, the interior, and that may make it more vulnerable to what they call microaneurysms, and that may ultimately lead to the hemorrhagic stroke, losing the integrity of those blood vessels.
Fascinating stuff. Shall we go to Dallas, Texas, and talk to Theodore?
Hi, Theodore.
Hi, this is Theodore. I really enjoyed your program today, and I especially liked Dr. Carroll's talk. I think he's very sane, and I've been in natural health since my 20s, and ate a maker's diet. My mother was a Jewish cook, and chicken soup, and she was. We always had meals as a family, and the atmosphere around the meal was very important. I find I'm 72 years old and I'm in very good health. And I find the attention on all the medical jargon and to be counterproductive. Much more attention needs to be put on stress, how much stress people are under in the modern world, and how much they worry needlessly about things that are not going to happen.
And I would also add how much they eat, because we eat way too much, and we eat too much of the wrong things.
But I think Theodore's point is important, that I think an important part of the Mediterranean diet is that people are sitting down, eating meals, taking their time, enjoying each other's company.
Thank you so much for the call, Theodore. We really appreciate it. Terry, shall we go to Steve in Dallas, Texas? Hi, Steve. What's on your mind?
Hey, Joe and Terry. I hate to be a contrarian, but my cardiologist has placed me on a high-sodium diet.
Oh, how interesting.
Why?
I was hospitalized about a year ago, and they found that I have apparently an uncommon heart arrhythmia, and I also suffer from orthostatic hypotension.
And orthostatic hypotension is when you stand up suddenly, you feel weak, and sometimes you fall over. So that's very interesting that with your arrhythmia and with your orthostatic hypotension, low blood pressure, what they've done is they've said you need to have more sodium. So you're not a contrarian, Steve. That's quite interesting and probably makes a whole lot of sense, Terry, don't you think?
Most likely, I think that Steve's doctor is paying attention to Steve's condition. And, Joe, we have an email from Ralph who says, tell us what a gram of sodium is in normal American talk. Well, 2.3 grams is about a teaspoon. So a gram is about a little less than half a teaspoon in normal American, okay?
Yeah, and, nobody is actually measuring how much sodium there is in the prepared food that they eat, but it's hidden in there, and it can cause an awful lot of trouble. Now, we are coming up on a break, and when we come back, we're going to talk with one of the leading experts on the FDA's adverse event reporting system. He'll share some surprising results about commonly prescribed drugs for pain.
Have you ever taken gabapentin or Lyrica? Share your experience.
Our lines are open at 888-472-3366. You can email us, radio@peoplespharmacy.com.
You're listening to the People's Pharmacy with Joe and Terry Graydon.
This People's Pharmacy podcast is brought to you in part by Verisana.com.
Verisana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's uppercase PEOPLE. To learn more, go to Verisana.com. That's VERISANA.com. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. If you'd like to purchase a CD of this show, you can call 800-732-2334. It's show number 1160. You can also find it online at peoplespharmacy.com.
The People's Pharmacy is brought to you in part by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. That's Kaya Biotics.com.
Now, we're still on the topic of evidence, but now we're turning to adverse drug effects, two medicines that are widely prescribed for nerve pain, and pain in general, Joe, are gabapentin and pregabalin, also known as Neurontin and Lyrica.
For more information on the side effects of these medications, we turn to Tom Moore. He is a senior scientist with the nonprofit Institute for Safe Medication Practices, and he's a lecturer at George Washington University School of Public Health.
Welcome back to the People's Pharmacy, Tom Moore.
It's a pleasure to be here, Terry and Joe.
Tom, you are one of the country's leading experts on tracking adverse drug events through the Food and Drug Administration's reporting system. Can you tell us a little bit about what it is you do, what it is that Quarter Watch does, and what the whole point of the exercise is about?
Well, Joe, I'm project director of a quarterly publication that we call Quarter Watch. And every quarter, we look at all the adverse events that are reported to the Food and Drug Administration. That's like 1 million a year. And we look for signals of emerging drug risks.
Well, the most recent Quarter Watch had some very interesting observations, and in particular, a category of drugs that I don't think people realize is prescribed in the kind of quantities that they are. And so first, let's just start with this idea of neurotransmitters. I mean, people have heard about serotonin and Prozac, and they've heard about dopamine, and they've heard about something called norepinephrine, but most people have never heard of something called GABA, an amino acid. What is it? Why is it important? And why should we care about drugs like gabapentin and pregabalin?
Well, Joe, if there's any one neurotransmitter that your readers ought to know about, and probably do in some fashion, it's GABA, because they are found in about 1/3 of all the little synaptic connections in your brain, and it's the downer. It is the inhibitor that opposes stimulus, which comes from down other circuits. So how would you know about GABA? Well, Alcohol connects with GABA. Anti-anxiety drugs like Xanax or alprazolam connect with GABA. So this is a suppressor or inhibitor function in the brain. And this particular family of drugs in our latest quarter watch are called GABA analogs. They are synthetic versions of this neurotransmitter.
How frequently are drugs like gabapentin or pregabalin, known as Lyrica, dispensed in this country? How many people take them?
When we looked this up, we were shocked. GABA analogs are taken by 10 million adults. Gabapentin itself is the second most widely used psychoactive drug of all of them, outnumbered only by Vicodin, which is acetaminophen and hydrocodone.
So what are they prescribed for?
Gabapentin itself has 3 very small approved medical uses. It's used as an add-on drug for certain forms of seizures, for example, but it turns out that it's being used and thrown into cocktails of every possible kind.
What else are these drugs approved for besides seizures?
Well, Lyrica is also approved for certain sorts of pain, diabetic pain, for example.
Well, I'm guessing that with all of the opioid concerns, and indeed we do have an opioid epidemic in this country, that a lot of physicians are looking for alternatives, and one of those alternatives for nerve pain in particular would be what we call the GABA analogs or the gabapentinoids. So a lot of people, millions of people, are taking drugs like gabapentin or Lyrica for nerve pain, whether it's diabetic nerve pain or whether it's some other kind of nerve pain. And what's the problem?
Well, the problem is that it probably doesn't work for most of those types of pain. It is used, and there are articles in other, prestigious medical journals pointing out that physicians are using this drug indiscriminately, just tossing it into pain medication, or they don't want to use an opioid, and so they toss this in with a drug like ibuprofen, a nonsteroidal anti-inflammatory drug.
Are they being prescribed with opioids as well?
Well, that's the problem, which is when we looked, and again, these numbers are just amazing. 32% of these patients were also regularly taking an opioid. So what we see in this data is not so much being substituted to opioid, but being added to opioids.
And what's the problem?
The problem is lethal overdoses.
Now, the use of these drugs, whether it's gabapentin or pregabalin, has really gone up rather dramatically over the last decade or so. Why do you think they're so popular?
Well, it's a sad story. The sad story, Joe, is that antidepressant drugs and our drugs for pain, truthfully, don't work very well, have a lot of drawbacks, including addiction. And so what's happening is people are not satisfied. People with chronic pain have a real problem on their hands finding a drug that works for them. And so here is this drug that just sort of got a reputation that it didn't deserve for possibly helping. And so doctors are just adding this to other cocktails of drugs that didn't work particularly well.
What are the side effects of drugs like gabapentin or pregabalin?
Well, there are 3 big ones. One is there are withdrawal effects. And so there are withdrawal effects, headache, nausea, all the withdrawal effects we would see, for example, with opioids. Secondly, especially when added to other drugs, it results in various sorts of mental impairment, confusion, falls. And thirdly, the big problem is depressing the central nervous system. You add this to another drug that's depressing the central nervous system, and you go too far, and bang, you're dead.
Tom, how would you suggest the FDA handle gabapentin?
We were shocked to discover that, number one, despite its withdrawal and potentially addictive qualities, it's not a scheduled drug. Now, Lyrica is. It's not. In fact, you can buy a month's supply for $12 at your local pharmacy. So clearly they need to re-examine that. Secondly, we need some policies and programs to prevent indiscriminate use of this in drug cocktails of sometimes 5 or 8 drugs, because sadly, physicians and patients are not seeing the response they wanted.
So, Tom Moore, a lot of the use associated with gabapentin in particular is what is referred to as off-label, unapproved uses. How would you like to see physicians and patients deal with these kinds of problems when there is not clear FDA approval for use in certain kinds of pain situations?
Well, I have 3 thoughts, Joe. First, we have to realize that a drug that might be valuable in some settings is dangerous or harmful or worthless in other settings. And if you want candidate number 1, it's gabapentin. Number 2, both physicians and patients should realize that this is a fairly risky drug, and you wouldn't want to just throw it into your regime with other drugs in hopes that it might do something, because it might do something, but it might do something that's harmful. And thirdly, I guess we all have to be realistic about the fact that we have some real limitations on all of the drugs that we have for very common conditions like depression, like chronic pain.
Tom Moore, thank you so much for talking with us on the People's Pharmacy today.
Joe and Terry, it's been a pleasure to be here.
You've been listening to Tom Moore, senior scientist with the nonprofit Institute for Safe Medication Practices, ISMP. He's also a lecturer at George Washington University School of Public Health.
Have you ever taken gabapentin or pregabalin? How well did it work to control your pain? Did you experience any side effects? Give us a call with your questions or your story. Our lines are open at 888-472-3366. You can send us an email, radio@peoplespharmacy.com. We can also be reached through Twitter. We're at People's Pharmacy. Again, that number, 888-472-3366.
Tom Moore mentioned that the indications that FDA has approved for both gabapentin and pregabalin are pretty limited, and really most of the 10 million people who are taking one or the other of these drugs are taking them for something other than what the FDA approved it for. So the question is, how well does it work for these off-label uses? A couple weeks ago in JAMA Internal Medicine, a special communication was published in the, I love this, their favorite category, Less is More, a clinical overview of off-label use of gabapentinoid drugs. And I have to tell you that basically what they say is the evidence is not good for these medications being used for general pain, non-diabetic neuropathy, and lots of other things.
Let's go to the phones, Terry, and talk to Lisa. Lisa, welcome to the People's Pharmacy. What's your experience with gabapentin?
So my experience with gabapentin is not an oral pill, but a cream. Had a surgery on an ankle and had just a lot of inflammation and, like nervy pain. And so was given this was like maybe 2012, 2013. And it was given a cream that has gabapentin and ketamine and a muscle relaxant, and I think it had ibuprofen in it as well. And it was a topical, and it worked great. And I held on to the last bottle of it, and a couple of years after that, I had tendinitis in an elbow, and the nerve pain there was awful, and I used it for that as well, and it worked great. And when I went back to the doctor to ask if I could get more of it, for the elbow, they said that they, didn't know anything about it, didn't know anybody that would formulate something like that. But that was, if we're having problems giving it orally, why can't we give these things topically?
Well, part of the problem, of course, Lisa, is that we don't have the evidence. We're really glad it worked well for you. but we don't have evidence that it would work for other people.
What's so fascinating about this cocktail, Lisa, is that it had ketamine in it, Terry. Can you imagine? So here's ketamine, which is officially an anesthetic, and just got a new drug approval for a chemical cousin, S-ketamine, as a nasal spray to treat depression. But as far as I know, there is very little data to support the use of topical ketamine as a painkiller. Now, it is a good analgesic, and it might work great, but I don't think we have much evidence.
And I have seen other compounded creams with gabapentin in them, for example, and we just don't have good studies to show, yes, this is exactly what you should be doing after ankle surgery or for tendinitis. We don't know.
Thank you for the call, Lisa. That
fascinating.
Was really interesting. Terry, let's go to Tampa, Florida, please, and talk to Chris. Hi, Chris. We understand that you're a veteran.
Hi, yes, I am. Thank you for taking my call today.
Yes, sir. What's your experience with gabapentin?
I was prescribed it at the VA to help with my pain. I have several herniated discs from an injury in the Navy, and so they had given me that and meloxicam. And what I found that works for me is they give me 300 milligram pills a day. So I just take the one at night because it makes me tired.
Right.
And I don't take the meloxicam anymore. I just take two. What is it? Aleve.
Right, naproxen.
It really helps. It really helps. I don't have as much of the shooting pains that I used to have. I'm still hoping to get surgery, but I'm trying to put that off to let the surgery and know more about surgery, because right now back surgery is really not a good experience for a lot of people.
You're so right.
And Chris, it does seem to have some real benefit for what we call neurogenic or neuropathic pain, and it sounds like that's what you're dealing with, nerve pain, and that is certainly an approved use for gabapentin. Thank you for your call. Bye-bye. And let's go to Pittsburgh. Hi, Ann. Welcome to the People's Pharmacy. What's your experience with, is it pregabalin, Lyrica?
With Lyrica. My doctor said I possibly had neuropathy, but I have no diabetes. He gave me Lyrica. First of all, it's very expensive, $700 for whatever it is. About 100 of these pills. It did absolutely nothing for me. The side effect was dizziness. Side effect was equilibrium. I stopped taking it, and now I'm fighting this dizziness and equilibrium, and I hope I can get that under control. But I tell people, don't buy Lyrica because it does absolutely nothing. It doesn't decrease, and I do have a little bit of pain in my feet, in the soles of my feet, but it's not neuropathy.
Well, and your experience is not unusual. Some people don't get benefit and do experience the dizziness that you mentioned, and we don't want to suggest that everybody fits into that category, because there are some people, Terry, who do get relief from Lyrica from nerve pain.
Well, primarily diabetic neuropathy. The evidence on non-diabetic neuropathy is not good.
Exactly.
It's not that that it says it doesn't work at all, but there's not much evidence that it does work. One last call, I think, Joe. Laura in Huntington, West Virginia. Welcome to the People's Pharmacy. What's your experience?
Yes, I have been taking gabapentin for about 5 years now, and I'm addicted to gabapentin.
It can be very difficult to discontinue.
It's not like you're getting high, so we want to make sure that people don't get the misinterpretation that you become addicted to it and you're getting high on it, but it's very hard to stop. And I don't think people realize that there is a discontinuation syndrome with gabapentin, and you have to phase off very gradually.
Yes, and not all doctors are aware of that, and so they don't necessarily help their patients taper as gradually as they might need to.
Exactly. Well, we didn't get to some of the other news, Terry. I feel bad about that. C. auris was in the news. That's a fungal infection that's sort of been sweeping the nation, and it's pretty scary.
It has developed resistance to fungicidal drugs.
That's right. Well, that's all the time we have. Thank you so much for listening. and for calling in your stories. We want to thank our guests today, Dr. Aaron Carroll of Indiana University School of Medicine and Tom Moore of the Institute for Safe Medication Practices.
Lynn Siegel produced today's show. Pamela Alberta provided technical assistance. Jenny Lawson provided engineering.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
To order today's show, you can call 800-732-2334. Today's show is 1160. That number again, 800-732-2334, or at our website, peoplespharmacy.com.
And when you go to the site, you can tell us what you thought about the show, or sign up for our free online newsletter, subscribe to the free podcast of the show. When you sign up for the newsletter, you'll also get our free e-guide to favorite home remedies. And if you listen to the podcast, we'd be grateful for a review.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you so much for listening. Please join us again next week.